In progress.
Hello, everyone. Good evening, everyone. It's my absolute pleasure to welcome you all to our third seminar, Bringing Light to Rare Disease and Awareness event. My name is Behnaz, and I am the chair of Purdue University Chapter of North, Students for Rare. Initiating and leading this chapter has been a journey filled with passion, determination, and a commitment to making a meaningful impact on the rare disorders community. Tonight's event is a testament to what can be achieved when students, faculty, researchers, and advocates come together for a shared purpose to amplify awareness, spark meaningful conversations, and foster collaborations around rare disease. I want to extend my deepest gratitude to our distinguished speakers, Dr. Erin Hoig and Abby Croth, who has joined online, for sharing their time, expertise, and stories. Dr. Hoig will provide invaluable insights into caring for children with rare disorders, a nurse perspective on treatment, family impact, and health disparities. Abby will share the rare and powerful voice of her daughter, Claire, shedding light with Phelan-McDermid syndrome, a perspective that reminds us why we are here today. Let's take this opportunity to learn from one another, ask questions, and build connections that can translate into actions for the rare disorders community. Our mission at the Purdue North chapter is to serve as advocates, researchers, and educators, united in challenges and victorious together. This event is not just about raising awareness. It's about inspiring all of us to think critically, act meaningfully, and support impactful change. Thank you again for being part of this evening. I hope it will be a memorable and inspiring event for each of you. Before we start the presentations, I would like to give you an overview of our student chapter. I would like, first of all, appreciate my team, Shima, Jafar, and Fatima. I couldn't accomplish these goals without my team. And of course, our advisor, Professor Robert Sterling. It's nice to tell you that how this journey was started. I actually had some questions that were not answered in rare community. So I was thinking that how can I educate myself and others to better support the rare disorders community? How can I access reliable resources to ensure accurate information and avoid misinformation? Why not establish a dedicated department with a specialist focusing on rare disorders? Is it possible to form a research team to develop orphan products or collaborate with global scientists to advance research on rare disorders? Could we develop a capstone course on rare disorders to educate patients, families, and scientists, ensuring that the latest information is shared to raise awareness? Additionally, could we consider writing a book specializing in rare disorders? All together helped me to be here. And it really impacted my research thoughts and all the thoughts, all ideas that I had. So far, the impact that we had at Purdue, at least, is the community engagement, organizational growth, and we had several impactful events for patients advocacy, education, and research purposes. And still they are going on. These are our achievements since January 2024. So we had several events and initiatives started in summer and also in winter. We had some research and presentations in October, July, and March. And we had, actually, I wrote a very short article about the challenges and opportunities in rare disorders. So I hope this helps. For community engagement and awareness effort, we also had a Be Involved cell. We engaged other students, undergrads, and even ordinary people who are still understanding about the disorder. And we also have been able to convince the business office to get the business account to hopefully get more money. Yes. So, and the plans as a chapter for 2025 is that we would like to have more interdisciplinary collaborations, multiple disciplines. That doesn't mean that only chemistry should be involved in this project. Research initiatives like imaging, genomic sequencing, and bioinformatics develop proposals for funding from national organizations like NIH or NORD and pharmaceutical companies interested in orphan products. Obtain IRB approval to write initial proposals for patient-based research projects. We already started this step with the IRB, and we would be very happy if you could join us and collaborate with this. And also the new part is the Rare Disease Advisory Councils. We have one in Indiana, and I would explain this to you more. So we can write, actually, we can make a law. So that's also one of my passions, to change some laws. My birthday is September 1983. It was the day that they had some, they made some actions regarding the orphan products and the disorders. So I'm very, very proud of my day. So patient awareness campaigns, like we would like to have more dance and tour on campus so that we engage with our faculty, and educational outreach, like having brochures, flyers, fact sheet, and PowerPoint presentations, so that we can help everyone to increase, including myself, to raise the awareness in the disorders. And of course, in strength and community engagement. This is RDAC. This slide, the credit belongs to National Organization for Rare Disorder with some modification. I should disclose this. And then tasks that we can achieve. So we can, as I said, we can change some laws. And Indiana is one of the states that we can contact federally, and we can ask what the rules and laws are, and then we can involve in their therapy, and hopefully this can impact Indiana state. And with that, I would like to invite Professor Erin Hoying to come and join us and give the presentation to all of you. Thank you. Thank you. Stop sharing and
Thank you for having me, everyone. So as Benna says, I'm Dr. Erin Hoying. You can call me Erin today. We're very informal. It's clear that she introduced. I'm going to share, my sister's going to share a little bit of her story about whatever avenue you're going into, and just being here is huge for our family, and for all the children like Claire. But a little bit about me, most of this perspective will come from sort of a nursing standpoint. I had a Mentimeter. I feel like we're a small enough group, you can all just kind of tell me. I would like to know like what your interests are. It'll help me kind of with my sort of presentation. But I've been a lifelong nurse. I graduated from Purdue. I've worked at Riley ever since I graduated. So worked with a lot of children with various rare diseases. And I will just say the leaps and bounds that these kids have now. I mean, we used to have very limited life expectancies. Now they're living into adulthood, which comes with its own challenges, sort of thing. But sorry. Okay, yes, I'm a mover too, so this could be interesting, but I'll try to stay.
Awesome.
She even knows this because she's my TA in PEDS class, so she knows like I'm a mover and a shaker and really interactive, but I will try to stand right here so people can see me. But so worked there as a bedside nurse, and then I did a lot of case management at Riley, and I still work there. So what that means as a nurse case manager or care manager is work a lot in transition planning. So what do these kids need to go home when they're in the hospital? How do we safely get them there? What are challenges that families see? What are barriers that they have? So really getting that other side of sort of thing, that psychosocial aspect as well too, so holistically, which is really my passion too, I'm really passionate about finding out who you're working for and caring for. So no matter what you're here today, if nursing, if you're hoping to go to medical school, bench science, I think even if you're a bench scientist looking for cures and things like this, I think having this perspective of who these kids are and their families is going to be huge for you. So I hope you take this information and all the great things it seems like this chapter is doing and move forward with volunteering and connecting with these families, because I do think it brings a lot of purpose. I just want to say I don't have a conflict of interest only because in these slides I put a few links to like some new genetic therapies of like drug sites. I definitely am not getting any kickback from it. Would probably not be here if I was, but I just want to make that really clear. There's just a lot of really cool things going on out there that I wanted to share. So objectives, I don't really like to call them objectives. I really just kind of hope when you leave here today that you're kind of looking beyond the rare disease to the person and the family, starting to introduce you to the wide range of rare diseases that are out there. They're just like endless, right? Whether it be infectious disease. I'm going to speak more to a pediatric side. So a lot of congenital anomalies, genetic disorders. What does it mean to care for them? What's the impact on the child? What is the impact on their family and their parents? The siblings is also a huge piece of it. And then, why is research so important? And I do want to speak to a little bit about the systemic and disparities and inequities that are present, because I think that's huge. All of this research and these drugs and everything, and even testing, it's a lot of money and there's a lot of disparities present, not just money, but even just so we still have a lot of mistrust in the healthcare system. So how do we reach everyone to get the best care possible? So I'm not going to pull up the Mentimeter, so you don't have to do this, but just briefly, if everyone wants to tell, does everyone want to share like either what your career is now or what your future career plans are if you're still in school? Don't help me with my presentation. Yeah. Yes, yeah. This is actually not my research specialty. I'm actually like more of I just got my PhD, but like a qualitative researcher, and I study like social justice perceptions of newly graduated nurses. So this is kind of just like my passion of what I do. So I haven't done research in this area yet, but I'm very happy to collaborate with anyone that would like to do some qualitative work. So and then I think this was kind of interesting. It's kind of just led into this. So if anyone has a prior experience with someone with a rare disease, and I already had people share, so do you know someone with a rare disease or you yourself? If you just want to raise your hand. We already a lot of us. Yeah, like, right. It's like so many of us, right, know someone either whether there be, congenital disease or has had a rare disease at some point. So I think that it's just important to note that like we've all been there and know someone with that. So again, I said mine is going to be focused mostly on pediatric diseases, rare diseases. So a lot of times we term these, you may see them called congenital anomalies if you haven't heard that term. Or birth defects is another way that they're often termed. I don't actually love that term, but these are a lot of times that we will see them. So when you see words like deformations, disruptions, dysplasias, syndromes, these are sort of all things sequences, like a Pierre Robin sequence. These are all sort of things that we think of that children are often born with. They occur actually in 2 to 4% of live born children, and so it's pretty significant. So sometimes they're born with them, sometimes not always, sometimes they happen later in life, but oftentimes too, sometimes they're genetic and sometimes they're not, right? Sometimes they just happen. There's chromosomal abnormalities. We can't really know why. We know that there's certain risk factors. And we do have a genetic component, so we can do genetic counseling, which is huge and is a huge field that people go into now, right? This genetic counseling and looking at the genes brings up all the genetic testing and things that we can do as well too that we learn about. So genetic disorders, so as I said, they can be caused by chromosomal abnormalities. So things like Turner syndrome or Down syndrome. So these are just when something is wrong in the chromosomes. They can be a single gene mutation, which could be, you know, autosomal recessive, autosomal dominant. We get into all that sex-linked, X-linked things like sickle cell anemia or a couple Duchenne muscular dystrophy. We can actually have these combination of things, combination of genetic with environmental factors. So we, for a long time, we used to say that we didn't really know what caused type 1 diabetes, but now we kind of know that there probably is some sort of what we call a genetic predisposition, and then something spurs it on, whether the child gets a virus or something like that, and then it just kind of reacts their immune system that way. And then we can have these mitochondrial DNA mutations as well too, which are not as common. And then in the chromosomal ones too, these are things, you know, we can have where a chromosome could be missing. Maybe there's more than one chromosome, so we could have a monosomy, a trisomy, that sort of thing. We also have these mitochondrial disorders, which are an interesting. So this is when I just want to say too that I am not like this kind of DNA stuff is not my specialty. So you guys probably all just hearing you speak probably are all way above me in knowing this. But this is when there's mutations in in the mitochondrial DNA. So I have seen these in my practice. We a lot of times in practice we will diagnose children with mitochondrial disorders when we can't find anything else wrong with them, which is interesting. Some families will take the diagnosis and be fine with it. Some families don't like that. They're like, we have no diagnosis of that. Don't take that out of my chart. I had a family like this one time and the dad would get so mad. He's like, we've had, they're kind of hard to diagnose. You have to take a muscle biopsy a lot of times, but the diagnosis could be hard. But he was like, we had a muscle biopsy. It didn't show that. I want that out of his chart. And we had to go through and like take everything out of his chart. It was just, it was a really big deal to him. So, but a lot of times, the constellation of symptoms can be varied too. We have some kids that will label with these that are very active, some kids that aren't and are like bedbound. So it's kind of an interesting field that I don't think I think it's kind of misunderstood, but and then we also have these inborn errors of metabolism. So these are inherited. Usually they're autosomal recessive, which I like to point that out because autosomal recessive is interesting because they can actually, because it's on that recessive gene, they can skip many, many generations. So they can kind of get lost a lot of times in translation. So these are when we have these interruptions in how the protein, carbohydrates, or lipids are broken down, which is if we can find what these are promptly and get them treated, these kids can have a much higher life expectancy, which is where we'll see, I'll bring up a screen about newborn screening, that those are so huge in our babies that we do. But if you think about when things aren't broken down right, we can have these rapid levels of ammonia rising in patients that can cause brain death and things like that. So this is why we do prenatal screenings, newborn screenings as well too. And again, these just present, there's so many of them. They present in all different ways, but maple syrup urine disease is one, phenylketonuria, galactosemia. So lots of different ones of these as well too. So we have two things. So we have genetic testing. So we screen versus diagnose. So there is a difference between screening and diagnosing. So screening is when we just do a screen, and just because it comes back positive doesn't mean that the child has it, right? But then we're going to go through the diagnostics of doing more definitive testing to see if they have it, which is where science really comes into play as well too. So a lot of times we target certain populations for early recognition, try to identify those carriers if we can. So a lot of times we're going back many generations to trying to get a good family history as well too, which anyone going to medical school or being a nurse or things like that, this is where history taking is so important as well too. And what we do in the United States is we have these newborn screenings. If anyone familiar with these newborn screenings? Yes, if you've had a child, when I used to work as a bedside nurse, it was actually my favorite job to do. And I used to float to the nursery on night shift. You had to like poke the babies and you got to take their little blood with a pipette. It was like probably the closest thing to me being a bench scientist, but you got to take like their little blood with a pipette like card thing. It's been the same method forever. I'm shocking that it's still this way. Yeah, it's just this little card. You got to fill in all the circles. I like loved it. It was like art time with like blood. Like it's kind of weird, but so they do that. So they do this newborn screening 24 hours usually after the baby is eaten to see how they're processing that food, that sort of thing. It tests, if you click these links, and I'll have you can share them as well too. If you click this link, it brings up everything that it tests for. So there's some that every state sort of tests for, things like cystic fibrosis. But each state has the right to add more or less. Indiana actually for a ton of metabolic diseases. And a lot of that is due to, we used to have some metabolic doctors at Riley that were phenomenal, like world-renowned speakers on this, and they were really big advocates of getting as many things diagnosed as soon as possible. And the reason is because a lot of these diseases, if we find out a kid has them, it's just as simple as saying like, oh, you have to, you can't have fat, or you need to take this medicine before you eat. So can really save their life and save their brain health and give them the highest quality of life possible. As far as getting diseases added to the list too, we can get them added. So a lot of times families, when they get diagnosed with the rare disease, I think the newest one in Indiana that was added was, it's called Pompe disease, Pompe. And there was a child that had this, and he's doing fine, but if they would have known sooner, he could have been a normal kiddo, right? And because they couldn't find out, he does have some disabilities. So how it works actually is it actually has to go to the state house and get approved by your lawmakers. So this is where advocacy comes in huge. I will just say that I've never seen a lawmaker not want to put one on the list. Normally it's a big deal. The family is there. It gets pushed right through. It's a big celebration that these families being advocates. But again, I just always point out this is why being informed voters and knowing your advocacy and things like this is huge too. So that's the Indiana. And then I put the one for every state is different. So if you go on there, you can look and see which states test for the most, which states test for the least. So it's just kind of interesting, the difference in different things. All right, so for systemic disparities, I just wanted to sort of point out is that a lot of times we have genetic bases for things like sickle cell anemia. We know tends to happen in certain populations, like the Black population. But it's also important to remember that race is really just a social construct, right? So everyone has the same sort of risk. So we need to make sure as healthcare professionals or people studying these diseases that we're reaching everyone as possible. So this image is from let's see, Freeman and Wojcik, in 2020, they did a research article and gathered some qualitative data. And these are all the points where you can see a barrier or disparity happen and breakdown. And this is huge because prompt diagnosis for these rare diseases, like I said, is a hallmark of getting these kids the care and the treatment and the services that they need. So we all have found that a lot of times, even if something is suspected, for example, if we just think about that screening, it's suspected on that newborn screening. So we call the family and need them to come in, get more testing done. But maybe family can't get there because of transportation or things like this, or they just don't follow up. So these are all barriers that are in place. So there's lots of areas for it to be broken down as well too. And in 2029, there was a study. So it's kind of an old study. It was based on children and adults, but they did find significant differences between racial and ethnic groups, both in the knowledge and concerns about misuse of testing. So I heard some people here wanting to say that they wanted to get some better education out there. So that's huge. About misuse of testing. So there's still that going on. A lot of times what we see, even when we think about stem cell, like the swabbing your cheek, we have a lot of mistrust on what we're doing with that, of taking our DNA and putting it in a database and that sort of thing. But they also found significant difference in screenings and things like that between types of health insurance, so government insurance versus private insurance, and then race and ethnicity as well too. And also, again, like I said, there's still a very large mistrust of the healthcare system. So working on breaking down those barriers as well too. So the role of the healthcare team, so of course it's going to be doctors, nurses, and many other people as well too. So we need to make sure that genetic counseling is done by properly trained individuals, which in the world of social media and Google can be challenging if you're to Google certain things. People can say they're an expert in a lot of different things that they're not. So making sure that it's done by the right people. So we have health professionals that work specifically in genetic clinics or with genomic research. The thing with this, again, when we go back to systemic issues, is that they tend to be consolidated in large academic health centers, right? Like people here in Lafayette are going to have to go to Indy or go to Chicago. So making sure that we have that even in our clinics in town and stuff too. But making sure that we're all prepared to understand genes and genomic, which is exactly like why I'm teaching genetics and genomics in nursing, right? Because I need to make sure that my undergraduate students are going out there with some knowledge of this happening. And then recognizing the need for genetic testing as well too. I think that that's always something that we can advocate for. A good family history is huge too. So not just asking the questions. Sometimes you have to probe families a little bit more when we're taking a good family history. It can't just be, oh, do you have any past history of genetic diseases? They might just say no, but then if you say things like, oh, or were any of your siblings, did they die at a young age unexplained? They might be like, oh, yeah, I did have a sibling that passed away when they were 4, that sort of thing with no explanation. So and then of course, health promotion practices as well too is huge. As I said, we know that like sometimes people just have a genetic predisposition. So even things like flu shots and things like that actually matter. Hand washing, making sure that we're staying healthy can be a good thing too. So these are just some really huge recent advances that we've had in gene therapy or genetics recently. So there's an SMA gene therapy. All of these links will take you actually to the drug. So there is an SMA gene therapy now, spinal muscle atrophy. It's just a one-time infusion, and it's showing some real promise to stopping the progression of the disease. So if you don't know about spinal muscle atrophy, there's a certain type where children don't have a long life expectancy. There is a child in Westfield, Indiana, which is where I'm from, that has this, and when the kind he has, his life expectancy used to only be like 2. And now he's all over like Westfield social media. It's his own page and things like this, but now he's like in like 2nd grade. So still's in a wheelchair and a feeding tube and things like that on his, but very huge. Cystic fibrosis gene therapy, I think, is probably one of the most significant ones that we've seen. So replacing that CTFR gene, and it's a pill that they take. They take it in the morning and the evening. Sickle cell disease is the most recent FDA one that was approved. And then psychiatric meds, there's actually a link to this. You can do genetic testing to see which drugs I actually heard it advertised on a podcast. So just kind of interesting. And then autism evaluations as well too. So the interesting thing with autism, I will say, and Abby may even speak to this, is that we have a lot more autism diagnosis, and now what we're doing now is when we send genetic testing, we're finding that a lot of these children have a chromosomal abnormality or genetic sort of disease too. So, all right, now we're gonna get on to the part about the care of the child and the family. So just always remembering the person. So first of all, the impact on the child, and really, I put delayed development up here. It's really a lot. That seems like such a simple way to think about it, but if you think about a lot of this is focused on the delayed development at each stage, these children are going to have consequences and suffering for these things that impact their families too. So what we see as the infants is they may not fully develop that sense of trust and bonding, which if you know an infant, that's a huge deal as well to have that sense of trust and bonding. Toddlers, they may not become fully develop that autonomy that we expect toddlers to, and it's not that they might not do it ever, but they're going to be delayed in doing that, right too. So my niece Claire, again, Abby, I'm sure we'll share this about her. She's hitting these things. She's just hitting these things in her own time, right? So, and we hope that maybe she'll get to the full impact of development, but she also maybe not, we don't know, and which is another huge impact of these families too that they deal with on a daily basis. And I'll talk about that as well too. So the impact on the family to remember is that they have lots of emotions and life changes. They overwhelmed. These love, fear, anger are just a few of the emotions that they will feel. Usually they're cycling through them in any one moment. Sometimes these families may feel all of these emotions all in one day, sometimes maybe even all in 1 hour. Lots of financial burdens, lots of altered family activities. So where things used to be so easy to go and do when they have these children, maybe they're not so um, easy to go and do, right? I always say, like, it's never just like going to the grocery, right? You got to load up them in their special car seat, get out their special stroller. Oh, we got to take their feeding tube because they're due for their feeding pump because they're due for their feeding. So all of those sort of things are just important things to remember and think about. Siblings oftentimes um, get impacted by being a sibling of a child with a rare disorder as much too. Sometimes they'll feel cheated of parental time and affection. Also, I've seen as these children get older, is that the siblings, a lot of times, as their own child gets older and parents get older, then they start to have this where they're like, I have to be the caretaker now of the child, of my sibling, and thinking about them. So it changes their whole sort of view sometimes on life, even what they're going to do in life. Where are they going to go to school? Where are they going to live for the rest of the life? So I will say, in my opinion, I've really only ever seen it be a positive come out of these kids. They end up to be very empathetic, compassionate people that always think about what somebody else is going through. But it is something that can needs to be remembered, especially when we're, as far as like thinking of a hospital, working in a hospital, that sort of thing was always something that when I was a bedside nurse, I would always try to, give my families that, it's okay to go home for a little bit. I've got your child. I can take care of them. They're safe. So just those little moments, or, if you know someone that has a child with special needs, just offering that sort of assistance to them too. All right. Chronic sorrow is something that I think is really the hallmark of children with these families, what they go through. So it's actually there is a middle range nursing theory of chronic sorrow. It's kind of based off this concept of chronic sorrow that was coined in actually the 1960s by a social worker named Ulf Schonke. So it's actually considered a normal response to a non-death event. So basically, it's just that these families like sort of have all of these. It's kind of like a cycle that they're always rotating through, right? It's a continuous grief response. So it's just a cyclical experience of loss, uncertainty, and disequilibrium, which is a lot of times exhausting and disorientating. So what we'll find too is that they'll often be triggered by certain events that come along in a child's age. For example, maybe if a child is 16 and parents should be excited, right? Because they're getting their driver's license. They know other year-olds that are getting their driver's license and their child is never going to have that experience, or, going to prom, those sort of things. So kind of going through this cyclic episode is really huge. And what we find is that when these families have a support system that they know that they can lean on and have somebody else tell them that it's okay. And this is something that, like, even with my sister and I, she may have various opinions. I like to think I'm a pretty good support to her, but I also know that sometimes her support group of other, moms that have kiddos with Phelan-McDermid is probably going to get her more than I do, right? Like, I have 2 children that are developmentally appropriate, they speak and things like that. So it's a huge deal for them to have these support systems. So daily stressors are abundant as well too. So just things you might not be thinking about, the things again families go through, their housing situation may change. You're thinking about somebody that's maybe in a wheelchair or something like that. Maybe they can't have stairs anymore in their home. They may have more technical things involved in their home now. Like Duchenne muscular dystrophy children a lot of times have to be on ventilators at home. So maybe we have families that now basically are becoming full-on nurses at home, right? Having to have ventilators, make sure they always have electricity. That sort of thing. Employment is huge too. So with employment, right, how much are they having to take off if, again, this kind of goes back to that systemic issues too, right? Some families don't have the luxury of taking off work when their special needs kiddos are sick, or their school is off, or their nurse is off, that sort of thing. But then again, the siblings as well too could be another thing that's impacted. There are times when these family members, we see them needing more support. Um, Anytime there's a transition, so that would be transitioning even from school, maybe they've been home and now they're going to school. Those transition times can be hard for them, moving, of course, anything. Of course, that first diagnosis is always huge, right? They're going to be hit with all those emotions of grief. And I think that that's important to know too, is that this really is, and that goes back to that chronic sorrow, it really is a grieving experience for these families their whole life, right? Like that they thought they were going to have this child, and then they have this new expectation, this new child. So anytime there's a change in prognosis, some of these rare diseases, we know that they progress eventually, and we sometimes we don't have a timeline, which super sucks and is super hard, right? We don't know when we're going to see them change or anything. I also work in the summer at a camp for adults with disabilities, and we had a camper that has a very rare disease. Like I forget the name of the disease, but like literally there's like 10 people in the country that have it. And her mom knew that it would progress. Seizures is a big thing with it, and she's known to have seizures. And she came to camp like one day, and I was like, I called her mom. I was like, "You're gonna have to come get her." I was like, "She will not stop having seizures." And when the mom came, she was heartbroken, and she was like, "I thought it was just me." She was like, "I know like that this is probably it, right? This is the prognosis is changing. We're gonna have to change." She's like, "I wanted someone else to see her because I thought it was me that was seeing it." So it can be really hard, right? So periods of developmental change as well too can sometimes when children go through the normal stages of development, we have a lot of challenges, and sometimes it's challenges with the child themselves behavior wise. Sometimes it's challenges with their health too. We see a lot of times in adolescence, children having more as hormones start raging up, they have more things like seizures or things like that too. So as healthcare managers, really our jobs are to make sure that we're advocating, which I've heard a lot of that here, so I think that's huge. Educating and support the child and the family, and then referral for resources. And with resources, I think it's important to know that we have to make sure we get those resources out to families, and I have a list of some here too. So resources they need, prescription meds, durable medical equipment, um, mental health a lot of times, education services as well too. So education, of course, in our country in here, they can get services up to the age of 21. And then after that, it's just kind of like, okay, like, so there's a lot of transition that needs to happen as well too, and thinking about that as well too. Financial assistance too, and then support for the family. So financial assistance, even families, if they have good medical care, it's never going to cover everything that they need for these, either for the medications, the gene therapy, the traveling back and forth to research, all those sort of things. This is just a small list of some resources. Of course, I put NORAD actually has some really good resources. Family Voices is one for advocacy. If you guys don't know about that one, I really like that one. It's pretty simple to use for families too. And it just really encompasses any child that has a special need. And then of course, the disease syndrome or specific organizations are huge. That's they do a lot of the research funding and putting out information as well too. And then we do have Medicaid waiver, Medicaid extended hours. So the Medicaid waiver, if you don't know about that, it's something that it's not dependent on your income, that these families, if they have a rare disease, that have disabilities, that they can get as a secondary to their insurance, and it helps pay for things like respite care. So that's another huge funding source too, just to think about as times change and money changes, how it gets spent and all that sort of thing. And then of course, multidisciplinary centers, these kids don't need usually just one caretaker. They need a whole team of people helping take care of them as well too. And then this video, if you, does everyone know Colin Farrell? He's in like a new show now, so I have people like on Max, the Penguin or something. But he actually has a son with Angelman syndrome, which is a pretty rare disease. And he was not super open about it for a long time. And then over the summer, he did, the video's like 15 minutes long. I encourage everyone, and the slides get sent out, to watch all of it. It's just he literally hits like everything that I would want to hit in a lecture. He talks about how hard it was to get a diagnosis. He was diagnosed at first. and how just, I think the one, there's so many parts that stick out, but one part he talks about how just having that diagnosis of knowing what was wrong, like, was just, it was a lot to take in, but that's a huge thing to these families, is having that that diagnosis, which goes into a lot of science and research. But he also talks about how the first time he walked, ever walk. And the first time he walked, I think he's like 4. And he just cried, and he kind of like, he starts crying in it. And he's like, it was just such a thing. But he says, he's like, it's something that everyone talks about, right? Everyone talks about their child taking the first steps. And I never thought my child would. And then he did. But he's coming out now and being more vocal because they live in LA, I think. But now he's past the age of 21, right? And now he's like, now I'm losing all these resources and I'm lucky. Colin Farrell, he's Colin Farrell, right? His son has like live and help and stuff. He's like, I'm lucky I have that, but I know a lot of people don't. So I just think it speaks a lot to the advocacy and the importance of this. All right, and so I'll get ready to turn it over to Abby, but as you've heard, so really all of my professional life, because my whole career doing case management, I cared for a lot of these kids with chronic and rare diseases. So then when my niece Claire was diagnosed, it really kind of intersected that professional and personal life, which I think was helpful, but also challenging at the same time. It's still something I deal with a lot, as well too. But all that to say that Claire is wonderful, and I do think that she was put on this earth for a reason as well too. I tell my sister that all the time, but I hope that Abby shares with you too. Speaking about the small things, is last night she FaceTimed me and she said hi, and it was like the biggest deal, like for her, like because like her vocalizing. So I'm hoping that Abby shares that with you. Put her on the spot. And then here's all my references, so if anyone would like those. So I'll turn it over to Abby to share Claire's story, which is pretty amazing too. So yeah.
Okay, if it's all right, I'll go ahead and share my screen.
Hi, Abby. Welcome.
Thank you so much. Okay, let me know if you can see my slides.
You can now see everyone in the room. Hopefully. Thank you so much, Abby.
Okay, is everyone able to see and hear me okay? Okay, perfect. Thank you so much for inviting me here tonight and letting me share our story of having a child with a rare disorder. This is Claire in the picture. She's 5.5 now, and she has Phelan-McDermid syndrome. I'm her mom, Abby, and I'm really going to be speaking on her behalf today, and as a family member of someone with a rare disorder. Claire's not here with me tonight because she would probably take over the whole Zoom and we'd be watching her favorite YouTube videos. And that's not what we're here for. So I do have pictures and one video of Claire while I'm talking to try to help you get to know her just a little bit. So Phelan-McDermid syndrome, also known as 22q13 syndrome, is a rare genetic condition involving chromosome 22 that can affect a wide range of critical functions in an individual, from learning and communicating to things like eating and sleeping. Right now, there are about 3,600 individuals with this diagnosis worldwide. It's likely underdiagnosed. In 2022, when Claire was diagnosed, the number of individuals who were diagnosed globally was 2,200. So even just in that time span, there's been quite an uptick in the diagnosis because we are learning more. There's more research going into it and more understanding of the disorder. So we're seeing more individuals who are accurately diagnosed with Phelan-McDermid syndrome. And I'm going to talk a little bit about some of the reasons that rare disorders like this are probably underdiagnosed, at least from my perspective and our journey. Just an interesting note for folks who are interested in sort of the genetic piece of it. I know Erin was talking about a lot of inherited genetic disorders. Phelan-McDermid syndrome is largely not inherited. It's a de novo deletion or mutation. So it just sort of happens. At least that's what we know right now, is that it just seems to be a bit random. In terms of signs and symptoms of Phelan-McDermid, it is really the widest of spectrums, to be honest. And so, there are folks who are, unable to walk or speak or communicate really in any way, can't self-feed, things like that. And then there are individuals with Phelan-McDermid who can carry on full conversations and are quite physically active. So there is a huge spectrum, but there are 3 very common symptoms, which Claire has all 3 of them, which are hypotonia or low muscle tone, developmental delays, and then delayed or absent speech. There's a whole other host of symptoms that can be associated with Phelan-McDermid syndrome. Some of the more common ones I've listed here. They include things like intellectual disability, sleep disturbance, difficulty feeding. About 40% of individuals with Phelan-McDermid syndrome end up having a seizure disorder as well. Oftentimes behavior challenges, kind of a random one, but decreased perspiration or heat intolerance. Also, not like feeling pain or experiencing pain in the same way is something that a lot of folks experience as well. And then there's a high comorbidity with autism spectrum disorder. About 75% of folks with PMS also are diagnosed with autism spectrum disorder. And this is certainly not an exhaustive list of the symptoms, but one thing that I think is important to note as well is that not listed on here, but it's also pretty common that Erin was just sharing kind of around different developmental milestones in life. Things can really change, and that is true for this disorder as well. Oftentimes in young adulthood, people with Phelan-McDermid syndrome experience pretty significant neuropsychiatric symptoms that can also be accompanied by a pretty extensive regression. So people who were doing a lot of things for themselves may be, completely unable to do that after, potentially seizures and neuropsychiatric symptoms accompanied by that regression. So, Phelan-McDermid syndrome is not a disorder that is necessarily life limiting in terms of like the age of how long they live, but definitely impacts quality of life. And sort of these unknown potential things that can happen really, really impact quality of life for them and honestly for their families too. So I want to share a video. I shared my audio. This is Claire's sort of playroom in our basement. So sorry for the audio background. I thought it would be nice for you to see sort of some of the ways that she communicates and kind of interacts just sort of in a typical way. So I'll share this and then talk about our sort of journey to her diagnosis.
1, close your eyes. 2, oh, you didn't count. Okay, where are the babies? I don't hear them. Oh, did you just see them? Oh. Did you see them? Peekaboo! You found them. You found them. Are they in there? I don't hear them.
Okay, so as you can see, she has, while she's largely non-speaking, she has a few words, but she's largely non-speaking. She communicates in lots of different ways, lots of gestures. She uses sign language. You could ask her, you could see her asking, can you hear them? And then, with different sort of intonation of her voice. So she communicates actually extremely well, for the fact that she doesn't actually have lots of words. And sort of some of these games like hide and seek, and playing these sorts of games are a very regular occurrence. She will play games repetitively like that, over and over and over again. It just never gets old for her. Um, so we began to notice, for Claire, things like low muscle tone and then just delays in gross motor development, probably around 6 to 8 months old, really around the age where you would start to expect to see some significant gross motor development, like sitting up, and those kinds of things. She didn't sit up on time. She didn't crawl on time, and then she walked quite late as well. And then around 1 year, when we would have really kind of expected to see sort of a language explosion, we also noted, delays in speech development too. Even before her first birthday, I shared concerns with our pediatrician. And I asked for early intervention evaluation, which the soonest she could get was on her first birthday. So we did that, right away. Both her pediatrician and early intervention evaluators did not have major concerns. So we're talking about multiple different professionals, medical professionals in different, from different professions. None of them thought they had major concerns. It wasn't until 2 years later, shortly before her third birthday, that we actually got her diagnosis of Phelan-McDermid syndrome. And I want to sort of just reiterate some of what Erin was talking about, in just that it can be really hard to get a diagnosis for a rare disorder. And it required a lot of advocacy and time on my part to get there, honestly. It took a lot of me sort of not just taking the first answer from people, and kind of continuing to push and push and push. So it was actually the second developmental pediatrician that we saw. The first developmental pediatrician also didn't have major concerns at that time. It was the second one that we saw who was like, these do seem like a strange set of signs or symptoms, right? Like, I think we should get a microarray genetic test and do an MRI and find out if there's anything to find out, right? And that is finally when we got her diagnosis. So if you can imagine, how frustrating that is, to know or kind of believe like something isn't right, and really well-meaning medical professionals, all of the people we worked with were wonderful. They didn't know. And they don't see kiddos with rare disorders a lot because they're rare disorders. And so they didn't think that the concerns that I had noted were as serious as what they actually ended up being. This picture is actually Claire and her brother. That's my son Ian, who is 10. I want to talk just for a moment about sort of the importance of having a diagnosis. I also agree that video of Colin Farrell is really moving. And part of the reason it's so moving to me is because he says exactly so many of the things that I have felt and thought. And so it really does capture a lot. But the importance of having a diagnosis is really multifaceted. So, while I understand that the sort of the spectrum of rare disorders in general, it kind of spans all kind of medical conditions, right? But I'm going to talk specifically about the benefits of diagnosis for kids with rare genetic disorders like what Claire has. The first thing is that it can be quite isolating and feel pretty devastating to have your child diagnosed with a rare disorder like this. And one of the reasons is that a lot of parents fear that there's just no hope for treatment, because who's working on a treatment for this rare disorder that no one's ever heard of, right? That's kind of what you tell yourself. And so that's part of the reason I'm here tonight is to thank you for your interest in this work and hopefully encourage you to continue on this path. But having a diagnosis connects you with community and support. You get to talk to other parents and families who are going through the same thing or have gone through the same thing. And that's really important just for your own emotional and mental health. Another reason is that, we know pretty much for any medical condition that the sooner it can be caught, the better. And that is certainly no exception for something like this. Particularly for kids, early interventions like occupational therapy, physical therapy, speech, ABA, which is applied behavioral analysis, those can be critical in sort of the trajectory of a kiddo who has developmental delays. And so, having a diagnosis at 10 months versus 3 years, I mean, that's critical timing. It's huge. So that's another important reason to get a diagnosis. Erin talked about this a little bit, and I'll just underscore it, that having an official diagnosis of a rare disorder can also make it easier to get access to certain benefits like Medicaid waivers and in obtaining necessary medical equipment. It can really be a lot easier to justify these requests when there's an established diagnosis of a chronic condition versus sort of these, somewhat, benign symptoms, right? Global developmental delay is what Claire that's what her diagnosis would be without actually having her diagnosis of Phelan-McDermid syndrome. So, as an example, Claire uses a special needs bed at night. And while we still had to justify it as a medical need, the fact that she has this diagnosis makes it so much easier for like the occupational therapist who's evaluating her. The OT isn't saying, well, she might outgrow some of these behaviors or whatever. It's like, no, she has this disorder. She's not outgrowing it. We need this. This is a long-term medical need. And so, for me as her parent, it actually makes advocating for her much easier as well. And then the last three, I think are really important and hopefully areas that speak to all of you and what you're interested in doing moving forward, or maybe what you're already doing. But having access to the knowledge and expertise on the specific rare disorder is just invaluable. So I put a link here at the bottom to the Phelan-McDermid Syndrome Foundation. They're amazing. They have a whole team of scientists and researchers and medical professionals. The foundation has advisory committees that have created clinical practice guidelines for different areas and specialties when it comes to Phelan-McDermid syndrome, which means for me as a mom, I can take Claire to see a dentist or a pediatrician and who doesn't know anything about Phelan-McDermid syndrome. And I can say, here are the clinical practice guidelines. Here's what's safe for her. Here's what works for people with this disorder, and have really a sense of security knowing that she's getting the best treatment versus sort of just kind of throwing things at the wall. The knowledge and expertise within these communities also lends to things like getting an ICD-10 code. Phelan-McDermid just got its ICD-10 code this year, so it's particularly fresh in my mind. If you don't know what an ICD-10 code is, that's a diagnosis code that gets used for billing and such. And things like this seem kind of boring, but they're really important. It allows this disorder to be analyzed sort of in its own bucket. It helps with things like insurance claims, coverage for treatment, making sure that everyone who's diagnosed is actually accounted for, and also gives pharmaceutical companies information so that they can look into launching drug programs. So it is incredibly important. lastly, for us as a family, it's really important for us to be connected to this community and have this diagnosis so that we can contribute to research and also benefit from research done. You know, if we didn't have a diagnosis, we wouldn't have a hope for treatment because, you know, we wouldn't know exactly what was going on. But right now we do have hope for treatment. And even though these might not be cures, you know, we have real hope that they can help us better manage and reduce symptoms, especially as Claire ages, and reduce the likelihood of that regression that I was talking about. So before I wrap, I do just want to touch on a couple of drugs in development for Phelan-McDermid syndrome for those who are interested in this kind of thing. One of them is a gene therapy, which is super exciting. You know, we're a little ways out. It's just recruiting for the phase 1 clinical trial. They'll start with 6 pediatric patients. And they're set to start just after the first of the year. So that's really exciting. The gene therapy targets the SHANK3 gene, which is, you know, while there are other genes that are often also deleted in Phelan-McDermid syndrome, SHANK3 is thought to be the cause of most of the symptoms that we see. And it's also a gene that's linked with autism spectrum disorder. So that's exciting. And then another drug that's a little bit further along and really focuses on brain cell and circuit connectivity treatment it's prepping for a phase 3 trial. Really excited. Actually, Claire is on an interest list for the phase 3 trial. So we're really hoping that we can get her involved with that. And the great thing about this drug is that it actually also has really promising results from phase 2 trials for other rare disorders like Angelman syndrome, Pitt-Hopkins, and Prader-Willi. So just a fun thing, each year Phelan-McDermid has a campaign to raise awareness around this rare disease. It's called the Phelan Lucky Campaign. And last year, we were so happy that the Purdue basketball team actually participated in this campaign and raised awareness for Phelan-McDermid syndrome. And this coming year, the dance team is going to be participating in the campaign. So if you don't follow the dance team on social media or something, do that and look out for them in January to promote this campaign. So thank you. I just want to say on behalf of myself and Claire and our whole family and other families like ours that, you know, your interest in this work is really important. And I know that it takes an incredible dedication to go into this line of work. There's lots of setbacks and starting over. But without people like all of you who have this interest, you know, our families would really be without hope for treatments. And so, you know, as I mentioned, with those drugs in development, you know, there's potentially light at the end of the tunnel. So thank you so much for your interest in this work and for having me here tonight.
Thank you so much, Abby. Yeah. So I would like to ask if you would like to ask any question from Sohoink and Abby. So that's the tunnel right now. There is a question on the chat.
There's no question in the chat, but then no, we are. His hand, so. Can you hear me better on that one? I think it's flat. Is it the line?
She might have quite.
Okay, so is there any question that you would like to ask Abby and Professor Hoing online?
guess I'll stop.
Yes.
Even having the foundation managed to go through getting that ICD.
Yeah, it's probably a question for Abby more, yeah.
Right,
I would think it'd have to go through like the government,
right.
see, probably Center for Medical CMS, right, Abby? You
If,
know?
you'll have to repeat the question because I can't hear super clearly.
The question was, they wanted to know how they got the ICD-10 coding done. Did it go through CMS, Center for Medicaid? CMS.
You know, I don't know the full process of how they did that. I'm sure that they would, the folks at Phelan-McDermid Syndrome Foundation are great. I'm sure they would be happy to answer that question.
You go to World Health Organization? Yeah. They create that. Well, so they create the codes and then individual countries then decide if they're having to change. And then those go through CMS. But you have to get it adopt those codes. But the WHO that's good.
Yeah, the answer really like, I feel like it was only 3,600 in the world. So like, to get that, it's probably a big deal.
Maybe it is better to come here. Abby, a lot of questions for you.
Can I ask a question from here, Behnazjan? Behnaz,
Yes, of
hear
course.
me? Sorry,
Navdar.
I am way away from you guys in the States. I'm calling from UK, London, actually. It's 20 minutes, quarter to 12 at night, but it's such an interesting seminar that I didn't want to miss it. Thanks to Behnaz. My question is a general one, both for Abby and Heather. I think it's about the gene therapy. I know that a lot of these rare diseases can be probably corrected at some stage with gene therapy. And does that gene therapy have to be applied soon after the diagnosis is made, or can it be done at any stage?
I could answer that a little bit specific only to the gene therapy for Phelan-McDermid syndrome.
Yes.
And actually, we just had an appointment last month at Rush Hospital in Chicago with one of the medical experts on Phelan-McDermid, and she's involved in the gene therapy study. And I asked her this exact question. And basically she said what they believe is that the gene therapy will benefit people with Phelan-McDermid regardless of age, but they do suspect that it will benefit earlier in development, which is why they're starting with pediatric patients for the phase 1 clinical trial.
Right. Okay, thank you. Thanks very much.
Speak just a little bit to what I know of the gene therapy drug. So again, I'm not super an expert, but what we know of like sickle cell is like that's the newest one, is that you can actually give that anytime and it will technically cure the disease. But it's like a very expensive and it's a very long process of being in the hospital for a long time. And then the cystic fibrosis drug that that's out there now. The really cool thing about that is that it doesn't really cure cystic fibrosis, but it truly impacts the kids. Like they have a much higher quality of life, so we see them in the hospital more. So it kind of will probably increase their lifespan even more than what it is, but they still have the increased secretions and things like that. But we're seeing less of like the progression in cystic fibrosis that eventually progresses to where they become diabetic because it affects all the exocrine glands. But we're seeing less of that. So having that introduced, and it also doesn't, that cystic fibrosis drug, it only works on certain kids that have certain genetic components. So it almost just kind of depends on, but the younger the better, which is that's a huge deal with the spinal muscle atrophy one, is getting that injected as soon as possible.
Thank you, Erin. Thank you.
Okay,
So thank you so much, Abby, for sharing this wonderful story and your journey. And please give our chapter's warmest regards and appreciation to Claire for being the star of the show. We really appreciate your time and support. So my question for you is, I know that it's been a while, but you've been going through some new treatment plans, and I was wondering if any of those are actually individualized plans, since this is like, as you mentioned, a kind of a syndrome with like the widest symptoms. So maybe it can be individualized to each person, and if so, have you tried any? And the other question is if you have ever tried any other sorts of treatments like art therapy or game therapy, and what was your experience? Did it actually work for Claire? Did she like it? So if you could share your insights on this, that would be perfect. Thank you.
Yeah. Thank you so much for the question. And I will say I shared I showed Claire the slides yesterday, and she was thrilled to see her herself on my screen on the computer. So she knows she's the star of the show. Yes, so we do. I mean, Claire's treatment is highly tailored to her needs. So just to give you a snapshot of sort of her routine and treatment that she gets, she right now, even though she's 5.5, she could be aged for kindergarten. She actually goes full time to ABA therapy, which is applied behavioral analysis therapy. So she has a wonderful center where she gets individual attention, and they have a very detailed, plan of what they're working on with her that we do in collaboration with our family. While she's there, she also gets music therapy and speech therapy while she's at ABA. So she does both of those. She does occupational therapy in combination with hippotherapy, which is horse riding. And she very much likes that. She's been doing that for a little while now. And she does like it. I mean, it's really great for her to engage in different activities related to like her sensory stimulation while also being on a horse. So yeah, I think it does. I think it does help her a lot to have sort of a variety of different experiences like that.
Perfect. Thank you so much.
Yeah.
I have questions. First, if you have any questions, I'm happy to stop and ask. Of course.
So if that's gene therapy for sickle cell disease, supposedly in other countries, sickle cell disease actually affects people from like malaria, parasites and things like that. So in terms of is trying to treat these patients for a disease and actually helping them protect from another disease. Where is the balance of what?
I'll be honest with you, sometimes all these genetic gene therapies really plays at my ethical strengths too. I get that, but I think at least I can only speak to this country. The impact that it has on these patients here. I mean, it's devastating, the pain that they go through. Their kids often undertreated. They get labeled as drug seekers at ERs and have to go through all of that. So I think here what we see, I think it would be very beneficial to them. Again, I don't know how many people it will reach because it's so expensive right now. I mean, I will say I have a lot of, Abby and I just had this conversation over text messages maybe last week about insurance wanting to pay for these treatments, of how, because to them, they just look, a lot of times insurance companies look at it as symptoms, right? Like we can manage the symptoms, so they don't want to pay for the gene therapy, which is really devastating, right? That you could get rid of this. So we've done some sickle cell transplants on patients, or not stem cell transplants on patients at Riley, kids that for whatever reason their sickle cell disease was so advanced they were young and getting admitted all the time. So, but again, it's so expensive. They're in the hospital for so long. So yeah, and it is really interesting. I haven't really thought about I guess the malaria aspect of it too, maybe having other drugs available for that too. Yeah. But I think in this country, I just think, and again, I don't know the worldwide, I probably should know the globalization thing. well, in other countries, I think in this country, it's definitely not treated as well as it should be. Even though one of the complications that come from it, the CDC actually has a whole task force on this because kids should be getting preventative screening. Things like that.
Any other questions? Hi, hi, welcome, welcome. Okay, I have a few questions, if you don't mind.
Yeah.
You get to the right time actually, because this is a roundtable discussion. And we are trying to ask questions and receive the insights from the professor, Hoing and Abby. So thank you so much for joining us. And please help yourself there. Yeah. Okay, so I have actually some questions. I promise not to give you very specific research questions, but I would love to hear much more about the research aspects of the the rare disorder. The thing is that we as a chemist look at the word differently. And I believe some of the symptoms that we know for rare disorders, they are all common. Like for example, heat intolerance that you mentioned, or for example, those people who are exposed to UV, they feel very, I should say, anxious, or even the disease gets worse. I'm one of those. So. I think the best question is that how we can approach the rare disorder. This is a very general question, but we can go deep if everyone is willing to hear more. How we can approach this kind of, research by using, like, for example, dried blood samples, and then start marking the metabolites and see which metabolites perhaps is related to, for example, heat intolerance or UV damage, for example. The UV is, like, for example, skin damage. For example, we have some diseases that when patients exposed to the UV, the DNA will be oxidized. And then we can monitor this, for example, on human blood serums for specific rare disorder. But the problem is that it's very hard to convince, researchers, patients even, to do this kind of, I don't want to call it projects, but research, So what do you, funding and all this thing. So what's your side?
I don't know. I think a lot of money talks. I think that's sadly what it comes down to a lot is like if you can come up with all these things, but if it's gonna be expensive to run the test, even like the genetic test that Claire had done to get her diagnosis right, we call it like a CNA panel. The interesting thing is when in a pediatric world, if a patient is an outpatient, Claire was lucky because she has private insurance, but in an outpatient world, to get that test paid for through like government funded insurance, it has to have like a prior authorization to get it done. You can't just run it. But if a patient's inpatient, like if they're in the hospital sick, you can send all these labs that you want off then, do all these rare genetic tests then, testing, sending things to NIH and things like that, and it'll get kind of covered under insurance because it goes under the hospital part of it. So I think that's, again, I don't know all the bench science part of it, but I think that's the most important thing that I think is trying to make these things more accessible to people and cheaper, and like being able to say things like if we can find an earlier diagnosis and it's going to save, it's gonna make these people or children have better qualities of life and all that sort of thing. I mean, I think that that goes a little way. And I think at the end of the day too, with genetic testing too, if you know, go almost too far off the deep end, right? If you start testing for too many things, then it's, you know, you're walking around your whole life like, oh, I might have breast cancer one day or things like that. So I think that there's like a fine line, but I think the importance is just that people know what they're getting tested for, right? Because of that mistrust in the healthcare system, and B, making it, I don't want to say cheap, but finding a way to make it cheaper, I think, to run to, it's still beneficial.
So you believe that, I really appreciate your answer first. So you believe that funding,
Like to get people to study it.
yeah,
Yeah, I think that funding for research, everyone can say here, is super high. I think that a lot of it is, especially in pediatrics, I give the lecture on cancer, and it's a big thing we talk about in cancer research, is that only 4% of federal funding goes to pediatric cancer research, which is like shocking. Only 4%, like the rest of it is all private donations. So I think that that's where foundations come in huge, right? Like in these grassroots organizations, like Allie was saying, the Phelan McDermott, like, right, they're giving grants for research, including, but sometimes relying on the federal funding
it's very
is very hard and challenging, right? Because you never know when it's gonna be used. I live in a world of nursing where if we get like one small NIH grant, like if we get even just passed to like the next phase, it's a big deal. Like, we just don't live in a bigly funded world. I get excited if I get like the $1,000 service learning grant, but you know, a lot of things we do is more, even in nursing, a lot of our big grants come from our nursing organizations, right? Grassroots funding. I think that could really, I think that that's where it's gonna have to come from, honestly, is, and I mean, it can be small things like even the little Phelan McDermott chapter that Abby, like her group, they're doing like a 5K, like, you know, in May, and like to help raise money and stuff like that. So I personally think that that's where funding is gonna have to really, because I think it's hard if people aren't, I think people don't always see the value in it, like, you probably get that right. People don't see the value until it impacts them. It's almost not like your research, like making your research valuable. Like it's hard for people, I think, to see. So I think being able to tell stories is I'm a huge
exactly,
story person,
exactly.
so.
Actually, that's something that I wanted to hear. And with that, Abby, I want to ask you a little bit tricky question, if you don't mind.
I don't mind.
So imagine that we have $100,000. So the funding that your sister actually mentioned is available. What would you like to do? You know, what would you like to suggest to researchers and scientists to do for your child?
That's a great question. And I'm going to cheat a little bit because I was actually part of, I was one of the family reviewers for the Phelan McDermott grant cycle this year. And so I got to see a lot of the grant proposals and sort of think through, like, you know, kind of also speaking to your previous question, like thinking through what has the most potential upside with the least amount of impact to individuals and families in any given research proposal. And so there's a lot of things, right? Like the pie in the sky, $100,000 isn't a ton, right? I actually think one of the things that is really important is being able to accurately measure different aspects of symptoms with people who, you know, we have these sort of self-report measures or these psychological tests that don't capture Claire. And so I have been a part of a lot of multiple studies for Phelan-McDermott syndrome. And I'm always like, I'm sorry to be such a pain, but that's not a yes or no question. I know on your piece of paper it is, but it's not a yes or no question for Claire. And so that's actually one of the things that I think we need to get better at, is having diagnostic tools that better and more accurately understand the full picture of people who are neurodivergent or who maybe have symptoms that are out of the norm. A lot of our tests are just not built for that.
I really appreciate that. So that's why I believe research will play a major role here, especially this is something that it comes from my heart, that we as a researcher should listen actually to Abby's, like people like Abby's, and see what they want. That's my perspective. And then we can think of how to design a research and perhaps answer the questions that family, does have. And they may not be able to interpret the results, but with not me, I have no qualification right now, but it, you professors, we are to maybe help them, to navigate this challenging, journey in a better way. That's why I asked this question.
I really appreciate that question. I think it's a great question. And even thinking about things like doing a medication trial, if the tools that you're measuring to look at the success of a medication trial aren't accurately, they're not asking the right questions, they're not measuring the right things, you're not going to know. And so I think the point you're making is really, really great in terms of because that's happened where there's medication trials like this, and the caregiver or the parents say, no, things are a lot better. But the tools or the tools that they're using to capture that wouldn't necessarily show it. But the caregiver is saying it is better. It's just because the tool isn't sensitive to the different aspects of individuals with these sort of different symptoms.
I agree with you, Abby. I have one more question for you, Abby. I mean, until morning I can ask questions, unfortunately. So my question is that what disease actually act similar to the PMS that actually impact, or it doesn't help to diagnose properly the PMS in your child?
So are you asking, are there other diagnoses that might be similar?
Similar disease, yeah.
I don't know if I know that I think you just said this, right? There are these sort of grouping of symptoms that are common across a lot of rare genetic disorders. And quite honestly, I think now what happens is a lot of times these kids just get diagnosed with autism spectrum disorder. And then they're not going through or being funneled to actually get genetic testing to find out what else might be going on. I know families, because Claire has an autism diagnosis. I know families that that's the case. I'm like, have you done genetic testing? Because it seems odd that, they also have this and this and this. And so I don't know if I could tell you, when I talk to people who don't know anything about rare genetic disorders or about Phelan-McDermid syndrome, sort of just the easiest thing I can say is I guess it's sort of like Down syndrome in a way, right? Where they kind of, that helps them to understand there's an intellectual and developmental delay component to it. And even though there are a lot of differences, that's the easiest thing that I have found to be able to kind of get people to be like, oh, okay, I understand that.
Thank you so much.